We are live.
Good evening, all. Welcome to iFocus Online, the 363rd episode, 38th in the Oculoplasty module. Today, we have with us our very own Dr. Raksha Rao from Narayana Nethralaya, Bangalore, to speak to us on thyroid eye disease, the diagnosis, clinical radiological evaluation, and its grading. Dr. Raksha Rao has her MBBS from the Father Muller Medical College and Hospital, Bangalore, and a master's in ophthalmology from the Topiwala National Medical College, BYL Nair Hospital, Mumbai. She's a fellowship in oculoplasty and ocular oncology from Center for Sight with Dr. Honava. And uh, as a continuum to it, at Wills Eye Hospital, Philadelphia, USA, under the legendary Dr. Carol and Jerry Shields. She's currently a consultant at Narayana Nethralaya, Bangalore. She's co-authored 28 chapters with Dr. Honavar on various topics, including retinoblastoma, orbit, and oculoplasty. She's the recipient of numerous awards, and to name a few, are the AIOS and IJO Platinum Award, the APAO Achievement Award, the APOS Pradeep Swarup Award, Best Paper Award in Ocular Pathology, Ocular Oncology at the AIOS 2019, OPAI Gold Medal for the first place in quiz at OPAI 2018, International Ophthalmic Hero Award at AIOS 2017 in Jaipur, Best Poster Award in Ocular Pathology for Physical Poster at AIOS 2017, Best Paper Award for Scientific Paper at Ocular Oncology Masterclass 2017 with Dr. Carol Shields in Hyderabad. Over to you, ma'am, for tonight's lecture.
Thank you, Dr. Subha, so much for the introduction. Um, Let me just. So my slides are visible?
Not currently, ma'am. Once you
Okay,
begin to screen share.
just a minute. Yeah. Is that good?
Yes.
Oh,
Can you have it in the slide share view, ma'am?
yeah, this is in slide share view.
This is in the
Ma'am,
view.
can you stop share for a minute?
Yeah. Okay.
Just click on the green button, screen share once, and on the
Okay.
pop-up, just click the blue button. Don't select anything, just click the green button and then the blue button.
Yeah. Done.
Now put it in slideshow mode.
Okay.
Still not there, ma'am.
Probably in the checklist box, there's a presenter's view. So you can just untick that box on the right-hand side. Yeah.
No, it's not on the presenter's view. Just a
Um,
moment.
It's actually in the presenter's view.
Yeah. So there where you can see the on the taskbar where it is help, right below that is the monitor and then the presenter's view. You can untick that presenter's view box.
This is on the Zoom
No,
platform
no, no. On your PPT.
on my PPT. Okay.
Just below the help menu view, there is just above your picture. There is the last
Okay.
one.
Yeah.
Okay.
Below that, yeah, just
Like that and then-
Yeah. Is this good?
now you can just slide share again. Just do this screen share again.
Okay. So sorry for the. Yeah. Is this good?
Not yet there, ma'am. Sunilji, could you help?
Sorry,
I
when
have unticked it. I have done.
just close the presentation and start again, ma'am. एक बार.
Okay.
Just close it once and then start. And when you do the share, please don't select the presentation. Just on the pop-up, just click on the entire screen rather than selecting the presentation.
Okay.
The pop-up that comes, it has to be the complete screen. First option left hand side, and then click the blue button.
Yeah.
Now
Done.
try to do.
Is this good?
It still shows the same thing, ma'am.
Why is this happening?
Doctor, just stop share for a minute.
Okay.
Just click on the green button once. This is the last
Share
time we'll
screen.
continue. Once, when the pop-up comes on, and there is boxes on the left hand side, entire screen.
So on the pop-up, there is just entire screen. Okay.
Yes, and then do the blue button,
See, there's no blue button which is
the
showing
share
right
button, the share
now.
button, the share button. After you selected the
Yeah, so it's
screen,
not
yeah,
in blue right now,
yeah, it's
unfortunately.
okay, it's okay, doesn't matter. Just click on
So,
the share button.
yeah, it's not sharing. When I click on
Once
the
you
entire
selected
screen,
the once you selected the screen, it should share. You selected the screen option, or we can yeah, the presentation. Just open the presentation now, or we can continue with the same way, ma'am. We have to just
okay.
open your presentation.
Now,
Yeah, just put it on screenshot. Yeah, perfect,
Yeah,
ma'am.
perfect,
Perfect.
perfect.
okay,
Yeah,
my
perfect.
God, that was quite a lengthy thing. Okay, anyways, sorry for all the technical glitches. So, as Dr. Subha mentioned, I'll be talking on thyroid eye disease. So, thyroid eye disease is a very vast topic, and very tactfully, this has been designed as a three-part lecture series. So, the first part of the lecture, that is the clinical radiological diagnosis and the grading system of thyroid eye disease, is something that I'll be discussing with today. This will be followed by the next two lectures by Dr. Honavar and Drs. Goldberg and Rootman in the next two parts that will deal with the medical and the surgical management. So, thyroid eye disease is also known as Graves' orbitopathy. This is because of its close association with Graves' disease. So, interchangeably can use TED or GO in various contexts. So, as we all know, the most common cause of thyroid eye disease is, most common cause of bilateral proptosis is thyroid eye disease, as also it is the most common cause for unilateral proptosis. So, what is thyroid eye disease? Basically, it is an inflammatory orbital disease. So, there is an inflammation in the orbit that is induced by this thyroid associated antigens. So, there are a lot of fibroblasts which are present in the orbital tissues naturally occurring, and when these get activated, and why these get activated, I'll be eventually following it up in the next slide. But these fibroblasts which are naturally occurring in the orbital tissues, when they get activated, they generate a lot of glycosaminoglycans, and these glycosaminoglycans get deposited in the orbital tissue, and they cause two important things. One is orbital expansion, that is increased orbital volume that leads to proptosis and optic neuropathy. And also, it causes compression of orbital structures. Mainly, there is impaired venous drainage that leads to periorbital edema, chemosis, and this compression can also lead to optic neuropathy. Now, like I said, what activates these naturally occurring fibroblasts into glycan producing fibroblasts is that there are certain triggers. These triggers are not in any and every individual. It happens in those who are susceptible and those who have autoimmune condition. Okay, so Graves' disease, as we know, is an autoimmune condition, and thyroid eye disease, which is closely associated with Graves' disease, is also an autoimmune condition. And what are these trigger factors? Trigger factors can be endogenous or exogenous. Endogenous factors are non modifiable risk factors, and this can be genetic or hereditary, increased age, or male sex. These are unmodifiable risk factors. What are exogenous or modifiable risk factors are smoking, high serum thyrotropin antibodies, thyroid dysfunction, and treatment of thyroid disorder with radioactive iodine. So these are the modifiable risk factors, and smoking is considered as the most modifiable risk factor, and it is very, very important that the history of smoking is included in any individual presenting with thyroid eye disease. So, when we talk about thyroid function and thyroid eye disease, you must remember that not every individual is either hypothyroid or hyperthyroid. Going by statistics, only 30% of the individuals are actually hyperthyroid, 30% are hypothyroid, and about 40% of the individuals are euthyroid at the time of diagnosis of thyroid eye disease. But going forward in the future, these euthyroid individuals, about 50% of them, eventually get converted into either hyper or hyperthyroidism, and hence even when an individual is noted to be euthyroid, it is very important that you monitor the thyroid function every 3 to 6 monthly to detect the presence of any thyroid dysregulation. So, thyroid eye disease, one must remember that it is a clinical diagnosis. It is not based on whether the T3, T4, TSH, or anti thyroid antibodies are raised or lowered. No, basically, thyroid eye disease is a clinical diagnosis, firstly. So you must remember that there are unique clinical signs associated with thyroid eye disease, and most of these clinical signs are rather important from exam point of view than a clinician point of view. So there are a bunch of names, and I'm sure the hot seaters here, just a moment. Yeah, the hot seaters here can help in naming some of the signs. So one of the commonest signs that you can find in an individual with thyroid eye disease is there is infrequent blinking. And what is it called? What is this sign called?
Stelvag sign.
Perfect. Okay. Lid retraction in primary gaze.
Dalrymple sign.
Perfect. Retarded descent of upper lid in down gaze.
Um,
One graphic.
Von Greaves. Yeah, Von
Perfect. So this is one of the most important signs. I mean, one graphic is the go-to sign. Okay. So it is almost universally present in all individuals with thyroid eye disease. Lower lid lag on up gaze. It's called Griffith sign, and deeper injection of the temporal conjunctiva is almost universally present again, and it is the Gold's-Ear sign. So all these signs, the paralysis of one or more extraocular muscle is called as ballet sign, and all these signs can be divided into four categories: lid signs, muscle signs, globe signs, and pupillary signs. So like I said, most of these signs are important from the exam point of view, and hence, like, I don't think the time would allow us to go through with every sign, but then for all those who have to make a note, can just freeze this slide and just write down the names and the explanation of each sign. So any individual that walks into your clinic with probable thyroid eye disease, is it's very important that there is complete documentation of all symptoms and signs. So some of the symptoms that patients with thyroid eye disease can present is non-specific, like excessive lacrimation, sandy sensation, like there is a foreign body sensation. There can be some discomfort, or there can be a deep retrobulbar pain, photophobia, red eye. All these are extremely non-specific. Some of the specific signs include eyelid retraction. So whenever there's an eyelid retraction, first thing you would like to think about is the thyroid eye disease. Puffy eye. Puffy eye is related to some edema around the eyelids. Bulging eye, that is proptosis. Double vision, reduced vision, all related to extraocular muscle and the optic nerve involvement. So, for documentation, one must always check with starting with visual acuity, color vision, and pupil. So, these are indicators of the optic nerve function. One must do a thorough examination of the cornea on slit lamp, because according to a study, about 10% of the thyroid eye disease individuals have positive corneal staining. And why does that happen? Dr. Subhav or Dr. Ruju? Why can there be corneal involvement?
Lead lag and exposure changes at night.
Correct. So there can be, because of lid lag, lid retraction, there can be some exposure. But what is also important is thyroid eye disease individuals, they can have deficient teophyl. Okay. So what we don't expect, and but what is proven and what is known is that there is a deficient teophyl. So there will be some corneal changes which has to be documented. Then there is always, you need to measure IOP in three gazes: up gaze, straight gaze, and down gaze. Why is that? Why is there IOP changes in thyroid eye disease?
Um, in up case, we might have a rise in the intraocular pressure.
Why does that happen? Yeah, it is called intermittent spiking of IOP. So why does that happen?
One is because of possible ocular motility restriction and raised episcleral venous pressure.
Perfect. Yeah.
Yeah.
So that's what happens. Okay. So in different cases, there will be motility restriction, which causes the pressure on the globe to mount, and hence rise of IOP. And always optic disc examination must be done, because if you need to note changes of hyperemia or disc edema. So you must also check the eyelid measurements, MRD1, MRD2, and entire measurement, because this gives you a measure of lid retraction. You must measure proptosis, and it can be done using hurtles or one of the exophthalmometers. You must check eye motility in all nine gazes, because during monitoring of the disease with medical management, one must see that there is an improvement in the ocular motility. Lastly, soft tissue signs, very, very important in thyroid eye disease. Why is soft tissue sign important in thyroid eye disease? Is because it gives an indicator of disease activity. Now, thyroid eye disease is a typically a biphasic disease. So there is an active disease and there is an inactive disease. So the first step in the management of thyroid eye disease is to establish whether the patient is presenting with an active disease or an inactive disease, and hence one needs to consider what is known as a Rundle's curve. So this Rundle's curve is beautifully described by Dr. Rundle in one of the publications way back in 1945, where he described that with rise in inflammation within the orbit, there is a rise in severity, and with the reduction in the activity or the inflammation in the orbit, the severity also comes down and it reaches a plateau phase. And this deficiency, the gap between the activity and the severity that you see, is due to probably the incomplete healing of the patient that leads to certain functional deficit. So, like I said, thyroid eye disease activity is one of the most important things that you need to monitor at the time of presentation. And this can be done using one of the grading system, which can be no specs, visa, CAS, or modification of CAS by the UGOGO group. So Werner's no specs ophthalmopathy index includes six parameters, out of which, sorry, seven parameters, out of which the first two have no number. N stands for no clinical signs or symptoms. O stands for only signs and no symptoms. Whereas the next five parameters, soft tissue involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss due to optic nerve involvement, can be graded as mild, moderate, and severe, with a maximum score that can come up to 15. Visa activity score by Dolman and Rootman has four different parameters, that is vision, inflammation, strabismus, and appearance. So you see that this is a very, very comprehensive classification, which includes various categories, various markings, various gradings, and this is a very useful way of assessing, especially in a patient who has had chronic thyroid eye disease and is coming to you again and again, and you need to assess everything in a very systematic fashion. But unfortunately, in the clinic that we see sometimes, and this kind of a comprehensive monitoring and recording may not be possible. And also what we have is a very simplified and a beautiful scoring system, which ugogo has given. It has four different parameters, out of which pain, redness, and swelling are the three parameters which you must assess at the initial visit only. So pain, there can be pain which is spontaneous retrobulbar, which gives a marking of 1. Pain which on eye which is there on eye movement, again there is a score of 1. Redness of the eyelid, which gives a score of +1. As you see in this patient, in the first figure there is no redness at all around the eyelid, but there is definite redness in the second picture. So that gives a scoring of +1. Fourth parameter, there's redness in the conjunctiva, which is greater than 1 quadrant, which gives the scoring of +1. If this conjunctival redness can be mild, moderate, or severe, as you can judge by these pictures. Swelling can be present in the eyelids, which can be again mild, moderate, and severe. The swelling of the eyelid can be described as thickening of the subcutaneous tissue. You can see the thickening in the skin here, or there can be a proper festoon formation, as you see in this picture. It can involve one eye, it can involve two eyes, it can involve one eyelid, or it can involve all four eyelids. Swelling of the conjunctiva, chemosis, again +1 scoring. And you describe chemosis as a definite chemosis when there is prolapse of the conjunctiva beyond the gray line. So swelling of the caruncle. Now, even that has a scoring of +1, and swelling of caruncle can be described as either chemosis or hyperemia of just the caruncle, or plus or minus plica semilunaris. So as you see in this second image, there is definite chemosis and hyperemia of the congestion of the plica semilunaris and the caruncle. So, when a patient is presenting to you for the first time with these symptoms, and you do a clinical scoring of +1 for each parameter, and the scoring comes greater than 3, then definitely the disease is active. However, when a patient comes to you on a second visit and follow-up visits, there is three other parameters which get added. That is worsening of proptosis greater than 2 millimeters over 3 months, or worsening of extraocular movement greater than 5 degree in 3 months, or worsening of visual acuity greater than 1 line over 3 months, again +1 scoring for each. And when the scoring is greater than a total of 4 on 10, then definitely the disease is continuing to be active even on follow-up visits. So UGOGO severity measure is where they have described, the UGOGO group, the European Graves group on Graves orbitopathy, has described the Graves disease in three different severity measures. The first one is sight-threatening Graves orbitopathy. Here, this can include either dysthyroid optic neuropathy, or there is a corneal breakdown, as you see in this patient. There is moderate to severe Graves orbitopathy. That is, here there is no sight-threatening Graves orbitopathy. However, it is severe enough to cause sufficient impact on daily life, which justifies the risk of immunosuppressive treatment. Mild Graves orbitopathy, when there is certain signs and symptoms, but it does not cause much impact on daily life, and it is these signs and symptoms are insufficient to justify immunosuppressive treatment. So, like I mentioned numerous times in this lecture, that thyroid eye disease is mainly a clinical diagnosis. So, you do not require biochemistry that includes T3, T4, TSH, and antithyroid antibody measurements for the diagnosis, as also you do not require CT or MRI for the diagnosis. However, imaging can be necessary, and Dr. Subhav or Dr. Ruju, can you please tell me in what situation is imaging necessary?
Ma'am, in cases of thyroid eye disease, we
Yeah.
would image ideally each patient whenever we plan on intervening with intravenous methylprednisolone to have a baseline record of how the radiological picture looks, and also with extraocular muscle measurements.
Perfect. Okay. And also, when there is certain doubt, you're not sure whether the thyroid eye disease diagnosis is correct, not correct, whether, you're looking at any slow dural arterial fistula, you want to make sure that this is what you're looking at. Okay. And also, when you are planning an orbital decompression surgery, because you want to get an idea of the overall orbital picture, how much of expansion there really is, whether it is the extraocular muscles which are mainly involved, or whether it is fat expansion, and where exactly you want to work in the orbit, and also to determine whether there is any optic nerve compression. So now tell me, would you order a CT or an MRI scan? Which is the preferred modality? Dr. Ruju, Dr. Subha?
Probably MRI for the soft tissue involvement, also for the extraocular muscle thickness, and for Barrett's index. For optic nerve crowding, we would prefer MRI over CT scan. But for planning for decompression, CT also adds well.
Yeah, so basically CT is the most preferred modality because because of the presence of fat in the orbit, it provides an excellent contrast as it is. So you can actually see the entire optic nerve, and you can also see the extraocular muscle, and you can see how much of the orbit is actually expanded. So CT is the most preferred modality. However, so what are the typical signs on CT scan?
Enlargement of the belly of the recti with scaly
Correct.
nodes.
Correct. So
Second
as
is
you can see here, there is expansion of the bellies of the medial recti, but there is no involvement of the tendon.
Second is an expansion of the intraconal space,
Perfect.
suggestive of, and then we also correlate that with muscle belly thickening to know whether it is a muscle predominant or a fat predominant kind of a thyroid disease.
Perfect. Okay.
Third is
So as
stretching of the
yeah,
optic nerve.
yeah. So you need to look at both the axial sections and the coronal sections. In the axial section, of course, you can make out the thickening of the belly and no involvement of the tendons. In the axial sections, as you go from antero-posteriorly, you look at the muscle crowding at the posterior orbit to see how much of volume consumption at near and volume crowding is happening near the optic nerve. Okay, so we also need CT scan for knowing the Barrett's muscle index. And Barrett's muscle index is basically used to determine the dysthyroid presence of dysthyroid optic neuropathy. It is determined by A plus B by C, as you can see here, or D plus E by F, as you can see here. And when this percentage is greater than 67, most likely the patient is likely to have dysthyroid optic neuropathy. And like I mentioned, CT is sufficient in most of the cases. However, thyroid eye disease also is an excellent modality to especially determine whether the disease is active or not, which is not you cannot see that in a CT scan. Of course, clinically you can determine whether the patient is active or inactive, but over multiple follow-ups with the steroid treatment and other kinds of treatment, sometimes the clinically the patient appears to have an inactive disease, but on MRI scan, when you see the T2 FS, T2 fat saturated scans, you can see that there is some hyper intense, you can see here there is hyper intensity streaks within the extraocular muscles, which is an indicator of disease activity. So you know that there is still some inflammatory activity going on the extraocular muscles, and this may guide your eventual treatment. Okay, so to summarize, in thyroid eye disease patients, first of all, clinical evaluation is most important. Documentation of the signs, symptoms, and the disease activity. Disease activity can be established using the clinical activity score to establish whether the disease is active, because that will help in initiating rescue therapy or the medical treatment, which will be dealt with in the next lecture series. If on clinical activity score the disease is inactive, then you just follow up the patient over a couple of months and years, and rehabilitative surgery may or may not be given to such patients. Thank you.
Thank you so much, ma'am, for the wonderful session.
Thank
And
you.
we thoroughly enjoyed it. And now, if you allow, I would like to take some questions from the social media.
Definitely.
Ma'am, so the first question is how to go ahead with a case uh, i- in a case with euthyroid levels, like what should we consider as a diagnostic?
So, okay, so when you talk about a euthyroid patient, I'm assuming that this is a patient who has walked into your clinic and who has certain signs of thyroid eye disease. That's what I'm assuming.
Ma'am, you need to check the presentation again. The presentation is not coming.
So, we don't
Yes,
need the
yes.
presentation.
You can stop, ma'am.
I'm sorry. I can stop sharing.
Yes, ma'am.
Yeah. Okay, so I'm assuming that this euthyroid patient that we're talking about has certain clinical signs and symptoms, and that's why he's walked into the clinic. Okay, say a patient has walked in and has some amount of lid retraction and has some discomfort in the eyes. So, first, what you do is you and you're suspecting that the patient is a case of thyroid eye disease, like I mentioned, you document the signs and the symptoms. And like I said, the most important thing is the clinical activity score. Take all the, and since this is the first time the patient is walked into your clinic, there are 7 parameters which are related to the pain, movement, pain on rest, and similar those 7 parameters. And if the parameters are the scoring is greater than 3 on 7, then definitely the patient is has an active thyroid uh, eye disease. Okay, now in a patient with active thyroid eye disease, it does not matter whether the patient is euthyroid or hyper or hypothyroid. You have to treat the disease as an orbital inflammation. Okay, it's a great thing that the patient is euthyroid, all right, but if the patient is hypothyroid or hyperthyroid, your additional treatment would be to send the patient to an endocrinologist and make sure that you correct the thyroid disorder so that the activity in the orbit is also controlled. However, if the patient is already euthyroid, it is a great thing that the patient does not require additional treatment for normalizing thyroid levels.
Okay, ma'am. Ma'am, next question we have is how to clinically assess a case of thyroid eye disease in a pediatric patient.
Okay, so in a pediatric patient, it can become quite challenging because, first of all, the patient is non-cooperative, and secondly, it's very rare that you see hypo thyroid eye disease in a pediatric child. So, mostly in pediatric cases, as we have noted, most of the children are hyper or hypothyroid, and hardly any euthyroid pediatric patients present to you. Okay, so they would have already come with a diagnosis of hyper or hypothyroidism, and then you assess on a similar note that you go with lid retraction, whether there is any orbital inflammation, any proptosis, similarly as you do in adults. But of course, you may not get accurate values, but the fact that the patient is hypo or hyperthyroid will add to your diagnosis.
And how to, ma'am, go ahead with imaging? Do we advise the patient to go ahead with CT or MRI straight away on first visit
In a pediatric patient, you see?
in a pediatric patient, ma'am?
In a pediatric patient, I would say that MRI would be better. Like I said, MRI is more informative as compared to CT. And especially in a child, this is going to be more important because clinically assessment may not be 100% accurate. And MRI scan, since it is safer, first of all. And secondly, it will help you evaluate the disease activity within the extraocular muscles, whether there is any inflammation or not. So definitely an MRI scan would be preferred in a child. And yes, you would order an MRI scan in the very first visit.
Okay, ma'am. Next question we have is importance of fundus or disc evaluation in a case of TED.
I mean, it is, I think I've already covered in this lecture series. Any patient that walks into your clinic and you're suspecting thyroid eye disease, there has to be a complete evaluation starting with visual acuity and intraocular pressure, corneal evaluation. There should be pupil examination, everything, and this includes posterior segment evaluation as well. Like we mentioned, there is in thyroid eye disease, due to the actual pathology where there is impaired venous congestion, it leads to, it may or may not lead to raised IOP. However, even in the presence of normal IOP, sometimes due to the compressive effects on the globe, there may be involvement of the optic nerve, and it may cause just hyperemia with or without disc edema. And hence, every patient of thyroid eye disease, the evaluation of fundus examination is completely valid.
Next question we have is what all things should be kept in mind while evaluating a case of TED undergoing treatment with IVMP?
Okay, so I think this part can actually be covered by Dr. Honava once he covers the medical management. However, what I would like to mention here is like thyroid eye disease is an orbital inflammatory disease, okay? And you're working around a very close space where you're dealing with the probable congestion in the orbit that leads to optic nerve decompression. So when you know that there is IVMP treatment necessary, all you need to do is the BP and sugar monitoring at the time of giving IVMP. However, if whenever we need to give IVMP, there, I mean, an endocrinologist can be definitely become a part of the team, and these sugar monitoring can be done. But IVMP has to be given at all costs.
Okay, ma'am. How to differentiate a case of TED from multifocal myositis clinically?
So, like I mentioned, on a CT scan or an MRI, clinically, yeah.
Clinically, ma'am.
So, yeah. So, clinically, first of all, the pain associated with the myositis is severe. It is mostly a very acute disease, and multifocal myositis, you can, whenever you ask the patient to do the 9 gazes, the pain is severe. You do not see a similar amount of tenderness and pain in a patient with thyroid eye disease. There is more of motility restriction than pain in a thyroid eye disease, whereas in myositis, pain is more than motility restriction. Okay, and radiologically speaking, of course, whenever in doubt, you go for radiological diagnosis. So on a CT or MRI, what you can see in multifocal myositis is there is definite tendon involvement, whereas in thyroid eye disease, there is no tendon involvement.
Okay, ma'am. And any particular points to be asked during history taking to differentiate between TED and multifocal myositis?
I would say that the chronicity of the condition, acute onset, that's all, because myositis is mostly an acute, subacute condition, and thyroid eye disease, the presentation is would be more of subacute to chronic.
Ma'am, how to avoid subjective variations in like while assessing the case, assessing the severity of a case? For sake clinical activity score, and suppose if I measure and someone else measures, there is a definitive difference between someone may feel like there is a caruncular congestion and someone might feel that there is no caruncular congestion. So how to avoid that subjective variation during assessment?
See, unfortunately, it cannot be avoided. But like I shown you the images, you definitely use these images in your mental map, and then you can make sure. And whenever, see, even as you saw in the images that I've showed you, when I mentioned there is conjunctival, there is congestion as a +1 score. It is not whether it is severe or moderate. So differentiating between a severe and a moderate case would be difficult. But conjunctival congestion, even mild, moderate, severe, is graded as a +1 score. Okay, so what you may call as mild, maybe Subha can call it moderate. Okay, but either mild or moderate, it can be plus, it is +1 only. Okay, so there's hardly any, I think, subjective opinion on whether there is no congestion or yes congestion. Congestion is congestion, it should be seen, is what I would say. Even with matter of lid edema, and like I showed you, it can be one eyelid, it can be four eyelids, it can be one eye, two eyes. But even in the presence of a little bit of eyelid edema, it is a +1 score.
Okay, ma'am. The next question we have is how to go ahead with a case of inactive TED and a clinical activity score 0.
So inactive TED, I would say, like we mentioned, the first step in the management of thyroid eye disease is to establish whether it is an active disease or inactive disease. And inactive disease is cool. You don't have to give a medical management at all. But in inactive thyroid eye disease, you have to see why has the patient come to you. Okay, is it the proptosis that's bothering him? Is it the squint that is bothering him? Or is it the eyelid retraction? Okay, so eyelid retraction is mainly an aesthetic concern. Proptosis would be an aesthetic concern also, but motility restriction would be the patient is presenting with diplopia. Okay, so based on what these symptoms are, what this presentation is in inactive thyroid eye disease, you go for rehabilitative surgery after establishing that there is no activity for at least 6 months.
And what should be the ideal follow-up in a case of inactive TED?
I would say that every 4 to 6 months.
Okay, okay.
Okay, and at the same time, the patient's T3, T4, TSH also is repeated every 4 to 6 months.
Lab investigations you advise to a case of TED.
Okay, again, underlining the fact that thyroid eye disease is a clinical disease, so biochemical evaluation is not necessary in all cases. However, in the first follow-up, you may want to advise T3, T4, TSH, and antithyroid antibodies, because these are the modifiable risk factors. When a patient is presenting with thyroid eye disease and T3, T4, TSH, and antithyroid antibodies, they are at abnormal levels, correcting these biochemical markers can help in control of the orbital disease as well.
Ma'am, can you please explain in brief about Nugent score?
About
Nugent score, ma'am.
Nugent score, I'm sorry, I'm not aware of it.
Okay, ma'am. Can you please explain the reason for temporal flare?
Temporal flare is yeah, so this is mainly because of the eyelid retraction. Okay, so it is seen that the lateral rectus is mainly involved, and there is congestion over the lateral rectus, which is reflected over the temporal region of the eye. As also, because of lid retraction, it is the temporal part of the globe that is mostly exposed, and most of the times it is the temporal flare that is visible more than any other part of the globe.
Is there any particular sequence of evolution of lid signs in active TED?
No, not at all. There is no particular sequence. No. And in clinical activity score, it includes the lid. Like I said, the clinical signs are just more important from exam point of view, not from a clinician point of view. And in the clinical activity score, the eyelid, there are only two parameters that are involved. One is whether there is eyelid edema or not, and whether there is eyelid hyperemia or not.
Okay, ma'am.
And of course, eyelid retraction, which is on follow-up. Yeah.
Okay, ma'am. So, is there any particular reason to commonly find inferior rectus involvement more frequently in the case of TED?
Yes, so you will see this answer in several textbooks. There's an explanation to this. When you go back and see the anatomy of the orbit, you see that the levator palpebralis and superior oblique muscle, and there is medial rectus and inferior rectus. However, in the inferior part of the orbit, there is inferior rectus, inferior oblique, along with a lot of ligaments. Okay, and the orbital structures in the inferior part of the orbit and around the inferior rectus, there are so many ligaments that there is more commonly involvement or along these and causing, which causes inflammation and scarring more commonly around the inferior rectus than anywhere else.
Yeah. So the next question we have is there any particular reason for aggravation of a severity of a case of TED with smoking?
Not really. No such cause has been established. It is just which has been studied and seen that smoking aggravates thyroid eye disease, but there is no proper effect and cause establishment as of now.
Okay, ma'am. Dr. Subhav, do you have any further questions?
No, like a lot of thank you and gratefulness for such a wonderful lecture, ma'am.
Okay. But
And
I think most of this you guys already knew, right? I mean, there was nothing new probably.
no, 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 we got a lot of. It was good to revise everything back,
Perfect.
have everything in a nutshell, and to revisit all those eyelid signs with a pictographic memory for future references. Ma'am, I had a question from my end. Like, what are the standardized testing conditions while doing a Hertel's exophthalmometry?
uh, like uh, you're asking me this not just from thyroid eye disease point of view, right?
Normally, ma'am. Yeah, ma'am.
In
Whenever.
general. So,
Yeah.
okay. So basically, you know that Hertel's exophthalmometer, it rests on the zygomatic arch, right? Yeah. So you must make sure that the entire scale of the Hertels is resting properly and straight on the zygomatic arch. And there are some people who have had fractures previously, and we may not be aware. So you must take a quick history whether there has been any injury or something, because if there is any part of the zygomatic arch that may have been injured previously, the Hertels just doesn't hold right. Okay, so you place the Hertels exophthalmometer here, and then to avoid parallax error, you sit right in front of the patient, and then make sure there is overlapping of the two lines.
One of the other questions which I had is whenever we examine a patient, say baseline or on follow-up, a case of an active TED, and then on our applanation tonometry by Goldman's tonometer, we observe that there are high IOP readings and that he's not on any anti-glaucoma medication. What are the factors do we consider, like as a novice, measuring this IOP for the very first time? What are the like physician-based factors, instrument factors, and the patient factors before we directly jump in to start an anti-glaucoma medication for the patient?
Yeah, so what we have been doing at Nara Nethralaya is this particular decision of starting anti-glaucoma medication is something that we have stopped taking the decision. We directly send them to glaucoma consultants. But what I have noticed is in any patient who has raised IOP, even in a particular gaze, say just up gaze, forget down gaze or straight gaze, just even in up gaze, they first get a visual fields done. Okay, so when the IOP is raised but visual fields are intact and the patient is the kind who would follow up, they do not start anti-glaucoma medication immediately. They wait for 3 to 4 months. They wait whether to see whether the effect of our steroid treatment, IVMP treatment, has had any effect on the globe motility reduction of IOP. They wait for 3 to 4 months and then do a visual field repeat and see whether anti-glaucoma medication has to be started or not. Okay, so this particular decision of starting anti-glaucoma medication, it's not with us anymore. We have a very comprehensive team, and I think that is the right way to go, because uh, their experience tells them when exactly it requires to be started. But again, it wouldn't hurt to start anti-glaucoma medication on our own in a patient with raised IOP for a couple of months, till you know that your treatment is going to kick in and the IOP is going to reduce. There's no harm in starting anti-glaucoma for a couple of months.
On the same note, ma'am, if I were to add a addendum to it, let us say that whenever we started the patient on, say, oral steroid therapy or intravenous methylprednisolone therapy, and then we realize that a patient is a steroid responder, then how do we go about this case? Like, just continue our treatment for active TED in conjunction with consultation of the glaucoma specialist?
Yes, I've had one patient like that who unfortunately had, fortunately had completely normal IOP before I started steroid therapy. But once I started him an IVMP, he came within 2 days saying his eyes are red and it's burning and he's not sleeping well. I could not pinpoint what the thing was until I checked his pressure. It was elevated. He was a steroid responder. Immediately sent him to the glaucoma department, and he was started on anti-glaucoma medication immediately.
And ma'am,
Okay.
what could possibly explain the dry eye disease in a patient with a active thyroid eye disease? Is it like the lag of thalamus or particularly at night, which causes this accentuation of dry eye? Or is it an increase in the ocular surface area where the lids are unable to cover? Yeah, or like what possibly explains the
It's a
dry?
mix of all these factors. See, for a proper tear film, we all know for a proper tear film distribution, our blinking is very necessary. We do about 12 to 15 blinks in a minute, and it is extremely important. So, one of the important signs that you see in thyroid eye disease is that there is infrequent blinking. Okay, as also there is lid retraction, there can be some amount of lag of thymus. All these factors leads to definite increased tear film breakup time. Okay.
Yes, ma'am. And also a last question for the postgraduates. Whenever they are two things, one on the theory front and the other on the practical exam point. If this active TED is given as a long answer question where possibly it is for 10 marks, how do you want them to basically channelize their thoughts in the examination where we have a paucity of time and yet everything has to be put on paper? One. The second set to this is in a practical examination, when so much has to be done in a workup for a thyroid eye disease, how do they mentally frame that uh, probably this calculating all the clinical activity score at once and then doing the measurement parts at once and then putting all together in a very short span of time? What advice would you like to give to the postgraduates?
See, a theory is something that I think can be covered in the exact manner as I have described. First, you go for symptoms, documentation of all symptoms, documentation of all the signs which we normally do in every patient, starting from visual acuity, pupil, IOP, cornea, blah blah, and till soft tissue sign, recording of soft tissue signs. Okay. So, however, on a practical note, when a patient is presented to you, and you have to document everything, like it has to be, you just go for the ask for the symptoms and go for the clinical activity score. Okay, forget about doing everything in a, proper fashion way, but just go for the activity score and you establish whether the disease is active or not. So one must go according to the clinical activity score with 10 parameters.
Uh,
Ma'am, one question I had from my end is how to assess a case of TED after intra-LPS steroid injection? Like, is there any particular measurements or is there anything particular we need to see?
Yeah, so after the intra-LPA steroid injection for a couple of weeks, you cannot definitely measure the lid edema, lid hyperemia, or the lid retraction part. Okay, for anything, it takes about 6 to 8 weeks to settle down. Once the trauma of you have iatrogenic trauma of you having been given the LPS steroid has come down, that takes about 6 to 8 weeks. Then you can assess in a very similar fashion. There should be no difference in how you would assess such a patient. Immediately post op, it is difficult to put down all these measurements because they are not valid.
yeah. Thank you so very much, ma'am.
Thank you so much,
Yeah,
Dr.
before we
Subha.
conclude for tonight, I have a small announcement to make. We
Uh-huh.
meet next on the 20th of December for the next lecture, Thyroid Eye Disease, the Medical Management by Dr. Santosh Anata. See you all there.
See you.
Good night,
Bye.
ma'am.
Thank you.
Bye,
Thank you
ma'am.
so much.